Imagine paying like $3,000 for a quick, one of those so-called lunchtime laser treatments.
Right, the ones that are advertised absolutely everywhere right now.
Exactly. The glossy brochure promises to rejuvenate your body, restore your confidence, and basically fix the natural effects of time with zero downtime.
Which sounds amazing, of course.
It does. But instead of walking out revitalized, you find yourself months later dealing with severe chronic pain.
Yeah.
And it's the exact kind of pain you were trying to cure in the first place. So today, we're taking a deep dive into the dark side of the vaginal tightening industry.
It really is an industry built on incredibly appealing buzzwords. But underneath terms like revitalization and tightening, there's this landscape of complex, sometimes extremely invasive medical interventions.
And when things go wrong in that highly sensitive area, they go wrong in ways that can, fundamentally alter your life.
Absolutely. The margin for error is incredibly slim.
Okay, let's unpack this, because that is exactly our mission today. Whether you're looking at surgical procedures like post-childbirth pelvic floor repairs or, gender-affirming vaginoplasties.
Right, the major surgeries.
Yeah. Or, on the flip side, you're being targeted by ads for non-surgical outpatient laser therapies.
Yeah.
We are bypassing all the marketing today.
We have to.
We're focusing entirely on the critical red flags. We want to know, what are the symptoms after a vaginal tightening procedure that demand immediate, urgent medical review?
Because knowing the difference between your body's normal healing process and a literal medical emergency is critical.
Right.
The pelvic region is highly vascular, it's densely packed with nerves, and it shares a very tight anatomical space with your urinary and digestive systems.
That's a crowded neighborhood in there. Before we can even begin to identify what requires urgent care, we have to define what this actually entails. Vaginal tightening isn't a real medical diagnosis, right?
No, not at all. From a clinical perspective, the phrase is pretty much meaningless.
It just sounds like a catch-all phrase.
Yeah, exactly. It covers completely different realities depending on who is holding the instrument. On one end of the spectrum, you have major surgical reconstruction.
Like using a scalpel.
Right. For instance, a patient might need their levator ani muscles repaired.
And those are what, exactly?
They're the muscles that act like a hammock supporting your entire pelvic floor. And they can be severely stretched or torn during childbirth.
Oh, wow. So repairing those is major structural work.
It is. Then you also have gender-affirming vaginoplasty. This can involve really intricate techniques like penile inversion, where existing tissue is carefully detached from its original blood supply and reshaped.
Okay, that sounds incredibly complex.
It is. Or they might use procedures that involve peritoneal tissue, which is a lining of the abdominal cavity, to construct an entirely new vaginal canal.
Wait, really? So that involves literally opening up the abdomen, taking tissue meant to lubricate your internal organs, and repurposing it?
Yes, exactly.
That is a massive physiological shift.
It's a profound surgery. But then on the complete opposite end of the spectrum, you have these energy-based devices.
Lasers.
Yeah, your CO2 or EREAG lasers or radiofrequency probes. They are heavily marketed as, non-surgical outpatient options.
Right.
And the mechanism here is heat. The device applies thermal energy directly to the vaginal walls to induce controlled tissue damage.
I really want to stop and look at that mechanism for a second, because the marketing implies it's like this gentle, warm breeze that magically makes collagen appear.
Right, the rejuvenation buzzword.
Exactly. But if we look at the physiology, it's closer to a controlled burn. You are essentially using a laser to inflict microtrauma on the tissue, right?
It is a much more accurate description, yeah.
So it tricks the body's immune system into rushing to the site, triggering an inflammatory response and laying down dense scar tissue, which the clinic then happily brands as new collagen.
Yeah, the heat denatures the existing proteins. You're basically injuring the tissue, so your body is forced to repair it.
Wild.
The resulting tissue is often thicker, which creates that sensation of tightening.
So it's like house renovations. Using a laser is like chemical peeling the wallpaper, while surgical vaginoplasty is knocking down and moving the actual structural wall studs.
That's a great analogy.
The normal mess left behind by both of those is going to look very, very different.
Exactly. Understanding that distinction between moving muscle groups with a scalpel versus applying thermal injury with a laser is the only way you can establish what a normal recovery should actually look like.
Right. So if you've just had a surgical vaginoplasty where muscles were sutured and tissues were entirely relocated, what is the expected baseline? Like, what shouldn't send you into a panic?
Well, with major surgery, the baseline for normal includes a pretty significant amount of temporary disruption.
Makes sense.
Mild spotting or oozing for the first few weeks is completely expected. You might experience temporary changes in discharge.
Oh, actually, you mentioned that abdominal lining earlier, the peritoneal tissue. Does that affect discharge?
Yes. If you had a peritoneal pull-through surgery, you will likely have a constant, clear, or yellowish watery discharge.
And that's not an infection.
No, not at all. That is simply the peritoneal tissue doing what it naturally does, which is produce moisture.
Got it.
You might even see a small amount of blood in your bowel movements for the first few days, simply because the internal surgical packing is pressing hard against the rectum.
Okay, that sounds terrifying, but it's good to know it's normal. Now, what about for the lasers? The controlled thermal burns?
The baseline for a normal laser recovery is usually just a sensation of warmth, maybe some mild irritation, slight localized swelling, or a watery discharge lasting a few days.
Just as the superficial tissue heals from the heat exposure.
Exactly. But what's fascinating here is how easily patients might misinterpret albeit strange biological repairs as a crisis.
Oh, like granulation tissue. We definitely need to talk about that because this seems to trigger a lot of unnecessary panic.
Granulation tissue is the perfect example of something that looks alarming but is completely benign.
So what is it?
When a deep wound heals, your body sometimes basically overproduces new vascular tissue. It's highly concentrated with tiny blood vessels.
Okay.
So to the naked eye, it can look like a bright red, fleshy polyp right on the star line. And because it is so vascular, it bleeds very easily if bumped.
So a patient might be like 3 months out from surgery feeling totally fine, and suddenly they see dark brown discharge or a splash of bright red blood after going to the bathroom.
Yeah, and they panic.
I think a suture popped and they're hemorrhaging.
Precisely. When in reality, it's just this tiny patch of overeager healing tissue.
Wow.
A doctor can treat it right in the office in about 10 seconds using silver nitrate.
Wait, what's silver nitrate?
It's just a chemical compound on the end of a small stick. The doctor touches it to the spot, and it instantly cauterizes the tissue, stopping the bleeding and flattening it out. No surgery required.
That's amazing. Okay, so some weird discharge is normal. A little bit of spotting from granulation is normal. But we need to draw the hard line here.
We do.
Where does normal end and danger begin? What are the universal alarms that apply to both the scalpel and the laser?
The line usually starts with the two most immediate localized signs of danger: severe bleeding and escalating pain.
Let's tackle the bleeding first. Because this area is so incredibly dense with blood vessels, I imagine a hemorrhage here can become critical very fast.
Extremely fast.
What is the exact threshold where a patient needs to stop waiting and go straight to the ER?
The clinical threshold is very specific. If you are bleeding heavily enough to soak through more than 2 pads in a single hour, that is an absolute emergency.
2 pads in an hour. Got it.
Furthermore, you need to look at the color of the blood.
Okay, why does color matter?
Because dark brown or dark red blood is usually old blood. It's oxidized as it slowly made its way out of the body. But if you are passing fresh, bright red blood in large amounts,
That's bad.
very bad, that indicates an active, ongoing arterial or venous bleed that hasn't clotted.
And bleeding shouldn't just be ignored if it happens months later,
Right.
like long after the procedure.
Correct. If you experience new bleeding immediately after having sex, or, and this is crucial, if you experience bleeding after you have already gone through menopause, you need immediate clinical evaluation.
Right, postmenopausal bleeding should never be brushed off as just a side effect of a cosmetic rejuvenation.
Never.
Now, I want to push back on the laser side of this for a second. If a laser is truly a non-surgical, non-invasive outpatient procedure, why are we even talking about the risk of severe bleeding or extreme pain?
It's a great question.
Right. If there are no scalpels, there shouldn't be hemorrhaging.
You are hitting on a massive controversy in the medical community right now. The marketing claims non-invasive, but the reality of applying deep thermal energy to delicate mucosal tissue is very, very different.
So the marketing is just lying.
Essentially, back in 2018, the FDA actually issued a major safety communication explicitly warning against the deceptive marketing of these energy-based devices.
Oh, wow.
Yeah, they noted that using them for vaginal rejuvenation has absolutely no proven benefit and carries very real, very severe risks.
They were seeing actual thermal burns, right?
Severe vaginal burns, intense scarring, and recurring chronic pain.
That's horrifying.
It is. These devices were originally cleared for entirely different procedures, like destroying abnormal cervical tissue. When clinics started using them off-label to essentially burn the vaginal walls for cosmetic tightening, the complications just skyrocketed.
There was a case study in the sources that really highlights the horror of this. It was a 65-year-old woman who underwent laser treatments purely to treat dryness.
Yes, I remember that case. A few weeks after her laser sessions, she engaged in intercourse and experienced immediate, heavy vaginal bleeding.
Just from normal friction.
Exactly. When doctors got her into the operating room and examined her under anesthesia, they found severe, deep lacerations across her vaginal walls.
Because the tissue had become so incredibly fragile from the thermal trauma that it simply tore apart.
It just couldn't withstand normal use, and the nightmare didn't end there for her.
No, it didn't. Several months later, she presented again with intense, unrelenting pain.
Right, because the natural elastic tissue of her vaginal canal had been completely replaced by fibrotic scar tissue.
Let's explain what that means physically.
Yeah.
Because fibrotic scar tissue sounds like a clinical abstraction, but the reality is devastating.
It really is.
Fibrotic tissue is dense, it's stiff, and it is completely inflexible. It does not stretch.
Exactly. And because of the sheer volume of this stiff scar tissue, her vaginal canal had essentially shrunk and contracted.
Just tightened up completely.
Yes. She developed severe dyspareunia, which is the medical term for severely painful intercourse, to the point where intimacy was utterly impossible.
So this quick lunchtime procedure permanently altered her anatomy and left her in chronic pain.
That's the reality for some of these patients, unfortunately.
Which brings us perfectly to the second localized alarm. Pain. If a patient is experiencing pain, how do they know if it's just a normal ache of healing or a massive red flag?
Normal pain should be predictable, and it should be steadily decreasing over time.
Okay, so it gets better every day.
Right. But if you experience severe pain that suddenly spikes, or pain that progressively worsens day by day, or an entirely new kind of pelvic pain that wasn't there immediately after the procedure, that is a huge red flag.
There's also a very specific visual cue linked to pain that requires urgent action. Sudden asymmetric swelling.
Yes.
What exactly is happening under the surface when one side of the tissue suddenly balloons up like that?
That is the classic presentation of a hematoma.
Okay.
When a blood vessel is nicked or ruptures under the skin, but the skin itself is closed, the blood has nowhere to go, so it pools in the surrounding tissue, creating a pocket of pressure.
Ouch.
Yeah. If you suddenly swell up on just one side of the surgical site, accompanied by deep bruising and intense throbbing pain, that blood is actively pooling.
And I imagine a pocket of blood in a space that tight is going to start crushing the healthy tissue around it.
It absolutely will. Now, small hematomas might eventually be reabsorbed by the body, but a sudden, large, rapidly expanding hematoma requires a surgeon to urgently open the site, drain the blood, and tie off the bleeding vessel.
Before it causes irreversible compression damage to the nerves.
Exactly.
So far, we've focused heavily on localized issues. Bleeding, tearing, hematoma. These are all happening right at the site of the injury.
Yeah.
But here's where it gets really interesting. Let's look at the systemic alarms.
The global alarms, yes.
When a complication breaches the pelvic region, how does the body sound the alarm? Like, how do you distinguish between local inflammation and a dangerous systemic infection?
Well, localized inflammation is simply your body sending blood and white blood cells to the specific injury site to start repairs. It's contained.
Right.
But a systemic infection means that bacteria have breached those local defenses, entered the bloodstream or deeper tissues, and are now threatening your entire body.
What's the biggest sign of that?
The most definitive global red flag is your temperature. If you spike a fever over 101 degrees Fahrenheit accompanied by chills or body aches, your immune system is fighting a systemic war.
So you can't just sleep that off.
Absolutely not. You need clinical assessment immediately, usually accompanied by aggressive antibiotics.
What about visual signs? What are the signs that an infection is spreading locally before it goes systemic?
Look at the redness. A little redness right at the incision line is completely normal.
Sure.
But if you see angry, hot redness actively spreading outward, expanding its borders day by day, that is cellulitis, a spreading bacterial skin infection.
Okay, that sounds serious.
It is. Furthermore, if a wound that was closed suddenly begins gaping open and oozing a thick, foul-smelling discharge, that is a clear indicator that infection has compromised the sutures and the tissue is breaking down.
The smell is a major indicator. And that leads to one of the most terrifying complications we need to discuss: necrosis.
Necrosis is tissue death, and it is an absolute drop-everything emergency.
How does that even happen?
This happens when the blood supply to a specific area of tissue is completely choked off. Without oxygen and nutrients, the cells literally die.
Visually, what does that look like?
You will see a distinct color change. The skin might turn pale, then deep purple, and finally pitch black.
Pitch black tissue.
Yes. And in gender-affirming vaginoplasty, where tissues are intricately rearranged, preserving the blood supply to the newly formed clitoris is paramount.
Right, because it's been moved.
Exactly. If a patient notices any blackening of the clitoris or the surrounding surgical flaps, it means the vascular connection has failed.
Oh my God.
And dying tissue often emits a very distinct foul odor. If you see blackening tissue, you do not wait to call the clinic in the morning. You go to the emergency room immediately.
Because the clock is ticking.
Surgeons only have a tiny window of hours to attempt to restore blood flow before that tissue is permanently lost.
That is incredibly sobering. Now, there's another systemic risk, specifically tied to patients undergoing major vaginoplasty, that doesn't involve infection at all, but is equally deadly.
Deep vein thrombosis.
DVT, blood clots.
Yes. DVT is a massive concern in any major pelvic surgery, but especially here. A vaginoplasty requires a significant period of bed rest and inactivity during the initial healing phase.
And not moving is bad for blood flow.
Exactly. When your legs aren't moving, the blood in your deep veins flows much more sluggishly, allowing it to pool and potentially clot.
But there is an added layer of risk for gender-affirming surgeries specifically regarding the medications patients might be on: estrogen therapy.
Yes.
Why does estrogen increase the risk of blood clots?
Estrogen naturally increases the production of certain clotting proteins in the liver. It makes the blood inherently stickier.
Okay.
So when you combine a patient whose blood is more prone to clotting due to estrogen with the prolonged immobility of surgical recovery, the risk of a DVT spikes significantly.
And if a clot forms in the leg, the danger is that it doesn't stay in the leg, right?
Exactly. The ultimate fear is a pulmonary embolism.
Which is when it hits the lungs.
Yes. A piece of that clot breaks off, travels up through the bloodstream, and gets wedged inside the lungs, cutting off oxygen exchange. It can be fatal within minutes.
This raises an important question. What are the exact symptoms? Like, when do you skip calling the surgeon's answering service and go straight to the ER?
The symptoms are very specific. If you experience a sudden, painful swelling in just one of your legs, not both, just one, that is a classic sign of a clot in that limb.
Okay, one swollen leg.
And if you suddenly feel dizzy, lightheaded, or experience a sudden, inexplicable difficulty breathing or sharp chest pain, you must assume the clot has reached your lungs.
That's a 911 call.
Absolutely. And the clinical guidelines are absolute on this. Do not drive yourself to the hospital.
Right, because what if you pass out?
The physical exertion of driving or a sudden loss of consciousness behind the wheel is just too dangerous. Have someone drive you or call an ambulance immediately.
Wow. Okay, so we've covered bleeding, tissue death, infections, and clots. Let's shift our focus back to the physical architecture of the area.
The pelvic floor.
Yeah. It is an incredibly crowded neighborhood. You have the vaginal canal,
Yeah.
but sharing the exact same property lines, literally millimeters away, you have the bladder and urethra in the front and the rectum in the back.
The anatomy is incredibly dense. Whether you are using a scalpel to physically move structural supports or you are applying deep thermal heat with a laser, you are sending shock waves through that entire neighborhood.
You can't avoid it.
No, you cannot perform major alterations to the vaginal walls without risking collateral damage to the plumbing right next door.
So what does this all mean for the surrounding organs? If a listener has undergone one of these procedures, what are the red flags that the adjacent plumbing has been compromised? Let's start with the urinary system.
The most immediate urinary red flag is retention. If you feel the urge to go, but you simply cannot pass urine, that is an emergency.
Because it backs up, right?
Exactly. Your kidneys are continuously producing urine. If the bladder cannot empty, it will eventually back up and severely damage the kidneys.
It's like fixing a pipe under the sink, but accidentally clamping the main water line. If nothing is coming out, you need to call the plumber immediately. Why does retention happen after these procedures, though?
It can be due to severe localized swelling, physically pinching the delicate urethra shut, Or it can be due to temporary nerve damage from the surgery, where the signal to release the bladder sphincter just gets scrambled.
Either way, you need a doctor.
Urgent medical intervention, yes, which usually involves a doctor inserting a catheter to manually drain the bladder while the swelling subsides.
What if urine is passing, but there is severe pain?
Severe burning during urination or finding visible blood in your urine stream are major red flags.
What does that mean?
It could indicate a severe urinary tract infection, or worse, that the urethra itself was nicked or thermally damaged during the procedure.
Oh, man.
Conversely, if you experience a sudden, severe worsening of urinary leakage where you completely lose control of your bladder, that demands immediate assessment.
Because the support structures failed.
Exactly. It often means the surgical repair failed or the thermal damage compromised the muscular support structures holding the bladder up.
Which brings us to the structural complications. Because we aren't just worried about the plumbing backing up, we are worried about the walls between the rooms completely collapsing.
Yes, it's the structural integrity.
And the most severe version of this is called a fistula. We need to explain exactly what a fistula is because the mechanics of it are horrifying.
A fistula is an unwanted, abnormal tunnel that forms between two organs that are supposed to be completely separate.
Okay.
In the context of vaginal surgery, because the vaginal wall and the rectal wall share a boundary, severe trauma can cause that boundary to basically dissolve.
Wait, how does the tissue just dissolve?
If the surgical dissection goes too deep, or if the thermal energy from a laser burns too intensely, the blood supply to that specific patch of tissue is destroyed.
So it's necrosis again?
Yes. Without blood, those cells die and break down. As the dead tissue slows away on both the vaginal side and the rectal side, a hole opens up connecting the two chambers.
Meaning that feces or rectal gas can leak directly into the vaginal canal.
Yes, it is a catastrophic complication.
Is it common?
It's relatively rare. Clinical data suggests it occurs in roughly 1 in 400 major vaginoplasties. But if it happens, it is physically and psychologically devastating.
And I imagine a hole like that, surrounded by damaged tissue, can't just heal on its own.
It cannot. It requires highly complex reconstructive surgery. Surgeons have to go back in, cut away the dead edges of the fistula, and often use skin grafts or muscle flaps from other parts of the body to patch the hole and rebuild a wall between the rectum and the vagina.
That sounds intense. It is.
If you experience unexpected discharge that smells of feces, or you are passing gas through the vagina, you must seek urgent surgical evaluation.
Okay, there's one more structural red flag we need to cover. A lot of patients who are targeted by the marketing for laser tightening are actually suffering from a completely different mechanical issue. What if a patient feels a deep, heavy, dragging sensation in their pelvis?
If you feel a distinct vaginal bulge, a deep heaviness, or a sensation that something is physically dragging downwards inside your pelvis, you should absolutely not be seeking a cosmetic laser treatment.
Because it's not a skin issue.
No, those are the classic mechanical signs of pelvic organ prolapse.
Meaning the hammock holding everything up is actually snapped.
Exactly. The levator antemuscles or the connective fascia have failed, and the bladder, the rectum, or the uterus itself is physically dropping down into the vaginal canal.
So applying a laser to a prolapse is essentially treating a snapped suspension bridge cable by burning the asphalt on the road below it.
That is exactly what it's like.
It does absolutely nothing to fix the structural failure.
It is entirely useless for prolapse. Worse, it delays proper medical treatment and subjects the patient to unnecessary thermal trauma.
Which we know can cause severe scarring.
Exactly. Device-based treatments should never, ever be used to bypass a proper medical diagnosis from a pelvic floor specialist.
We have covered incredibly heavy terrain today. Let's synthesize this. Whether you are dealing with the thermal burns of a laser or the massive structural shifts of a scalpel, the red flags are absolute.
They are heavy bleeding, meaning soaking 2 pads an hour, or passing bright red arterial blood.
And systemic alarms, meaning a fever over 101 degrees, spreading redness, or the foul odor of blackening necrotic tissue.
Right. Sudden asymmetric swelling that could indicate a hematoma, or sudden shortness of breath indicating a blood clot.
And finally, severe urinary retention, new and extreme pain, or symptoms of structural collapse like a heavy bulge or the horrifying signs of a fistula. None of these can be chalked up to a normal healing journey.
Absolutely not. The ultimate takeaway here is that you must advocate for your own clinical assessment.
Right, because vaginal tightening and rejuvenation are just marketing buzzwords designed to sell you a product.
They are not clinical realities. If your body is sounding any of the alarms we've detailed today, do not let a clinic dismiss your pain.
So important.
Seek out a qualified, independent medical professional like a gynecologist, a urologist, or an emergency room doctor to get a proper evaluation.
Trust your body's alarm systems. They're usually right. We spent today deeply focused on the physical, anatomical red flags of these procedures.
Yeah.
But considering how intensely the cosmetic industry weaponizes the natural effects of aging and childbirth, convincing people to endure risky, sometimes agonizing procedures just to fix their confidence, it leaves us with one final thought.
Which is?
We know how to spot a physical hematoma or a structural prolapse. But are the psychological red flags of an industry that sells profound physical trauma as a lunchtime glow-up ultimately the most dangerous complication of all?
That is something to think about.
Keep an eye out for those buzzwords and stay curious.